Welcome back to the deep dive. Today, we are undertaking a critical and frankly fascinating exploration of the human renal system.
Mhm.
If you are preparing for a session on fluid balance, diuretics, or, hypertension management, this deep dive is your highly efficient foundational shortcut.
It really is.
It helps you understand exactly why those drugs work the way they do.
That's absolutely right. Our mission here is to synthesize the foundational concepts of kidney anatomy, function, and systemic regulation, really giving you the key nuggets from the source material.
And the scale is just astounding.
It is. What is astonishing right out of the gate is the sheer scale and importance of these two small organs.
They are so small, but they punch way above their weight. Dramatically.
Dramatically is the word. Despite making up only about, 0.5% of your total body weight, the kidneys demand a massive 25% of the body's entire cardiac output.
25%.
A quarter of the blood pumped by your heart every single minute is rushing straight to the kidneys
That is just an incredible vascular demand. Why such a high volume?
because they're constantly cleansing and balancing. They process around 1,600 liters of blood daily, filtering it over and over.
Wow.
But here's the efficiency metric you really need to nail. They're so good at their job that 99% of that fluid that gets filtered is immediately returned to your body.
So only 1% actually leaves.
Only about 1% or, less than 2 liters leaves as urine.
That efficiency is a work of art. Okay, let's unpack the blueprint first. Where are they located, and what protection does the body afford these vital regulators?
Well, they're strategically located high up under the ribs. That gives them immediate physical protection.
Okay.
And they're enclosed in 3 protective layers. The inner fiber capsule, a layer of perirenal fat, and then the parietal layer.
And I think I remember reading something important about that inner fiber capsule. It has a kind of clinical significance when things go wrong, doesn't it?
It absolutely does. The capsule is rich in pain fibers. This means that if the kidney tissue swells, maybe from an infection or some inflammation.
A capsule stretches.
Exactly. The stretching of that capsule is what causes that sharp, intense pain, often associated with renal issues. It acts as an early warning system.
I see. So structurally, we move from that protection inward, and we find the 3 regions, the outer cortex, the inner medulla, and the renal pelvises.
Which are basically the collecting funnels that route the final urine product into the ureters.
Got it.
But the true microfactory of this system is the nephron. This is the key functional unit.
The workhorse.
It's the workhorse. An adult typically has around 2.4 million of them.
2.4 million. That is a massive amount of redundancy.
And that redundancy is the critical clinical takeaway here. We estimate that only about 25% of your total nephron population is actually required for healthy, normal function.
Wait, hold on. That's a powerful insight. That means if a patient has a condition like hypertension or diabetes, silently destroying their system, by the time they start showing clear signs and symptoms of renal failure, 3/4 of their backup system is already compromised.
Precisely. That massive reserve is why chronic kidney disease is often called the silent killer.
So true.
Now let's look at how the filtration happens in this microfactory. The journey begins at the Bowman capsule.
I found the description of the capsule fascinating. It's like a biological sieve.
It really is. The capsule's epithelium is described as fenestrated, which just means it has these tiny window-like pores.
Okay.
This membrane is permeable to water and small molecules, but crucially, it blocks the large stuff, blood cells, and most importantly, large proteins.
So if we see protein or blood cells in the urine later, that tells us that primary sieve, the Bowman capsule membrane, has been damaged.
A textbook sign of renal damage, yeah.
Yeah.
Once filtered, the fluid flows through the long, coiled, proximal, convoluted tubule down and up the loop of Henle.
Then the distal convoluted tubule, and finally into the collecting duct. And the blood supply that feeds all this is just completely unique. It's not a simple arterial inlet and venous outlet.
No, it's a 2-arterial system, and that's the key to local pressure regulation. The afferent arteriole branches into that high-pressure knot of capillaries called the glomerulus.
Right.
But instead of exiting directly to a vein, the blood leaves through the efferent arteriole.
I was surprised to read that instead of a simple vein, they have this second structure. Why is that specific 2-arterial system so crucial for filtering?
Because it allows for close automatic regulation by constricting or dilating either the afferent, the inlet, or the efferent, the outlet.
The kidney can control the pressure.
It can tightly control the pressure specifically within the delicate glomerulus. This ensures a consistent filtration rate even if your systemic blood pressure fluctuates a little.
And finally, the structural link that ties this local system to the rest of the body is the juxtaglomerular apparatus.
Correct. It's a group of specialized cells located right where the afferent arteriole connects to the distal tubule.
And that area is the production site for two major systemic regulators.
Erythropoietin and renin.
Okay, that wraps up the blueprint. Once we understand the structure of the nephron, the natural next question is, how does this sophisticated plumbing actually decide what stays and what goes?
Right.
It boils down to three sequential processes.
Exactly. Glomerular filtration is that first step we just covered, the passive, pressure-driven passage of fluid through the Bowman capsule.
Okay, step one. Step two is tubular reabsorption. This must be what defines that 99% efficiency you talked about.
This is the system pulling all the good stuff back from the filtrate into the vascular system.
Things like water, glucose.
Water, glucose, electrolytes, vitamins, sodium bicarbonate. It's an essential process, and it often involves active transport systems that require energy.
And here's where pharmacology becomes immediately relevant, right? When we introduce drugs that affect renal function, they often work by overwhelming or just jamming those specific transport systems.
A perfect connection.
Yeah.
They interfere with reabsorption, causing substances to stay in the filtrate and get excreted.
Right. And the third process.
The third is tubular secretion. This is the active, energy-using movement of waste products from the blood.
From the blood into the tubule.
Specifically from the peritubular capillaries into the renal tubule for excretion. This is crucial for removing certain drugs, uric acid, and most importantly, hydrogen ions.
It's the final sweep of the system. Let's dive into how the body meticulously fine-tunes all this, using hormones to manage fluids and electrolytes. The cornerstone is sodium regulation.
Sodium is the body's major cation, and its active transport drives everything else. It is actively reabsorbed in the proximal tubule.
And because of osmosis and electrical balance,
Water and chloride ions passively follow the sodium right back into the blood.
I think the chemistry involved in this section is perhaps the most mind-bending. It involves the enzyme carbonic anhydrase.
It's truly elegant. Carbonic anhydrase acts like a catalyst. It rapidly speeds up the reaction that combines carbon dioxide and water.
CO2 and H2O.
Right. This forms carbonic acid, which instantly dissociates.
And that dissociation creates two vital things simultaneously. Sodium bicarbonate, which is the body's essential alkaline reserve, its main buffer system.
And a free hydrogen ion, an H+ ion. That hydrogen ion stays in the filtrate, making the urine slightly acidic, which ensures acid-base balance is maintained.
Wow, so the kidney is constantly generating the alkaline reserve while simultaneously dumping the acid waste.
All in one move.
Incredible. And sodium levels are fine-tuned further down the line by aldosterone.
Aldosterone, which comes from the adrenal gland, acts primarily on the distal tubule. It controls a critical sodium-potassium exchange pump.
Okay, so its job is what?
Its job is to retain sodium, and therefore water, while actively pushing potassium out into the urine for excretion.
So if a patient has high potassium levels, the body signals for aldosterone release just to get rid of that excess potassium.
Exactly, even if volume retention isn't the primary goal at that moment.
Right, and the flip side of that is the natriuretic hormone.
Yes, which is released when the body senses fluid overload. This hormone decreases sodium reabsorption, promoting water loss and resulting in a diluted urine.
Now for the physics magic. How the nephron creates the massive gradient needed to either hold on to every drop of water or dump it completely. This is the countercurrent mechanism in the loop of Henle.
This is a complex concept, but the result is simple. Creating a hypertonic, a high-salt environment in the tissue surrounding the loop. Think of the tissue around the loop of Henle as a massive salt magnet or sponge.
And the opposing flow is key to how it works.
Precisely. In the descending loop, the membrane is freely permeable to water. As the filtrate goes down into that salty magnet tissue, water just rushes out passively.
Concentrating the filtrate.
Exactly, concentrating the filtrate as it travels down.
But the magic shift happens at the turn. The ascending loop is impermeable to water. Water is locked in.
Correct. Instead of letting water out, the ascending loop uses an active process, the chloride pump, to actively transport chloride ions out of the tubule and into that surrounding tissue.
And sodium follows the chloride.
Sodium follows to maintain electrical neutrality. This process is actively building and maintaining that high salt gradient in the surrounding tissue. Meanwhile, the fluid left in the tubule becomes incredibly dilute hypotonic.
That highly concentrated tissue surrounding the loop is then leveraged by the body's ultimate volume controller, antidiuretic hormone, or ADH.
Yes, ADH is produced in the hypothalamus, stored in the pituitary, and it's released when the body senses rising sodium or falling blood volume.
And it acts where?
ADH acts directly on the distal tubule and the collecting duct. If ADH is present, it essentially flips a switch, making those membranes permeable to water.
And because the collecting duct is surrounded by that high salt tissue we just discussed, the moment the switch is flipped, water rushes out of the filtrate.
And you excrete a highly concentrated small volume of hypertonic urine.
And if ADH is absent?
If ADH is absent, the membranes remain impermeable, the water is trapped in the tubule, and you excrete a large volume of dilute hypotonic urine. It's the ultimate water management system.
Okay, briefly, let's just touch on the other vital electrolytes.
Sure, potassium fine-tuning is heavily influenced by aldosterone, which dictates potassium loss. Calcium regulation involves parathyroid hormone, or PTH, acting on the distal tubule for reabsorption.
And the kidney also has a role with vitamin D, right?
A crucial one.
Yeah.
The kidney is responsible for activating the ingested vitamin D, which is non-negotiable for calcium absorption in the GI tract.
Okay, so if we connect all this back to the bigger picture, the kidney is not just balancing what's inside, it's a master regulator of systemic blood pressure,
Absolutely.
which leads R into the emergency alert system of the body, the renin-angiotensin-aldosterone system, or RAAS.
RAS is the compensatory life-saving system designed to maintain perfusion blood flow to the fragile nephrons. The trigger is always the same: decreased blood flow or oxygenation.
Like from a sudden hemorrhage, shock, or severe hypotension.
Right. When the juxtaglomerular cells sense that drop in flow, they immediately release renin.
And renin sets off the cascade.
It activates angiotensinogen into angiotensin I. This then travels to the lungs, where an enzyme converts it into angiotensin II.
And angiotensin II is the immediate punch in this system. It is one of the most powerful, short-acting vasoconstrictors we have.
It is. It raises blood pressure almost instantly. It's the body's attempt to get blood to the brain and other vital organs, like right now.
Then there's another step.
It also quickly converts to angiotensin III, which then stimulates the adrenal gland to release aldosterone,
So you get the quick fix from vasoconstriction.
followed by the volume fix from sodium and water retention via aldosterone.
This entire cascade is designed to boost volume and pressure. And there's a fascinating feedback loop here with the brain, isn't there?
There is. The osmotic center in the brain senses the increased sodium from the aldosterone action and then releases ADH, which causes even further water retention,
It's a runaway train designed to save you from shock.
which is an essential concept for understanding pharmacology. When we administer a powerful drug like a diuretic, that lowers blood volume.
The RAS system senses that drop.
It senses that drop in flow and immediately triggers this protective cascade, often leading to a challenging rebound fluid retention.
The kidneys have a second massive systemic role, managing the production of red blood cells.
Yes. Those same juxtaglomerular cells are monitoring not just blood flow, but also oxygen delivery. If oxygenation is low, they release erythropoietin
Which signals the bone marrow,
to ramp up red blood cell production.
which gives us the clear clinical tie. Patients in chronic renal failure frequently develop anemia because the kidney loses its ability to produce that essential erythropoietin.
And finally, we touched on their role in acid-base balance, maintaining the alkaline reserve of bicarbonate and actively secreting hydrogen ions to keep the body's pH stable.
That's a comprehensive look at the kidney itself. Final segment, a quick tour of the rest of the plumbing, the urinary tract.
Sure. Once the urine leaves the renal pelvis, the ureters use muscular peristaltic waves to move the urine down to the bladder.
And the bladder itself has a protective mechanism.
It does. It stores slightly acidic urine. That low pH actually helps destroy bacteria that might enter.
Okay, let's discuss the key clinical differences in the urethra structure, specifically regarding infection. Why is cystitis so much more common in women?
It's purely anatomical. The female urethra is significantly shorter, and it's closer to the natural flora, including E. coli, is a much easier, shorter route for bacteria to ascend into the bladder.
Whereas in men, the urethra is much longer and has an additional structural nuance. It passes through the prostate gland.
Right, and the prostate gland is important because it produces an acidic fluid essential for sperm viability and lubrication.
So the common clinical issue in older men is
That if the prostate enlarges or becomes infected, it can directly impede urine flow through that longer male urethra.
that brings us to the end of our deep dive into the renal system. What are the 2 or 3 most essential takeaways for our listener today?
The foundation, I think, lies in the nephron's 3 processes: filtration, reabsorption, and secretion. Those dictate volume and composition.
And beyond that.
Beyond that, the sophisticated regulatory systems, RAAS, ADH, and aldosterone, are what ensure systemic stability of volume, pressure, and electrolytes. Understanding the triggers and end results of these hormonal pathways is just essential.
Thank you for joining us on this deep dive. So what does this all mean for you? This raises an important question. Considering the immense power of the body's emergency alert system, the RAAS, and the precision required by the countercurrent mechanism, how does a drug designed to interrupt just one component of this cascade like an ACE inhibitor blocking the conversion to angiotensin-lipase create such global cascading effects across blood pressure, volume, and electrolyte profiles throughout the entire body? It underscores the immense power and the necessity for precise monitoring involved in pharmacologically manipulating these minute yet globally influential transport pathways.